We can pick up from where what we were talking about last time. Again, with the brain stem, we have the vomit center, and then we have the area postrema, or the central trigger zone. A lot of communication between them. Let's go ahead and collect a few other dots here if we could. We certainly understand that the higher brain centers can be communicating with these as well. So there is good evidence that we can have communication higher brain center and the vomit center. We also have communication of the higher brain center and the CTZ there. Again, all this is coordinated because we spoke last time that nausea is not a brainstem phenomenon. You can have stimulation of the vomit center, but your subjective experience of nausea is involving higher brain centers, so there has to be conversation from these areas to have the nausea, of course. Another thing I want to bring in, and we spoke of this earlier, I think, was that you have the notion of motion sickness. The vestibular system can be involved in emetic events as well. And so if we're talking about the vestibular system, we're talking about the inner ear. So we have a structure called the labyrinth. And the labyrinth, there's part of that we call the vestibular labyrinth, and that is, again, your sense of balance. So what you have is you have some neurons that are sensing what's going on in the vestibular part or in the labyrinth, and you got little hair cells that are bending in response to motion, and they're going to release neurotransmitters, stimulating a sensory ganglia here, and that ganglia there is called Scarpa's ganglia. Okay, and that is responsible for anything to do with, motion or a sense of movement or acceleration. These neurons are going to come in, and they're going to communicate with several vestibular nuclei in the brainstem. So the vestibular nuclei, again, would be a secondary sensory neuron. And so the vestibular nuclei, they're going to be located in the pons and in the medulla of the brainstem. And so they're going to be talked to, in a sense, and then neurons from the vestibular nucleus can in turn then talk to the vomit center for appropriate coordination. So again, you can have motion sickness. Again, you're going to have the communication between the inner ear to the vestibular nuclei and then on to the vomit center for possible emesis and certainly nausea. All right, so let's talk a bit about some of these receptors that I have. These are little cartoons I have drawn out, and this is again where the abbreviation is helpful. So we'll go ahead and start with the vomit center itself. So what we have here is this is going to be the H1R. That's going to be histamine type 1 receptors. So they're involved in the vomit center. I'm going to have M1 receptors, so this is going to be muscarinic receptors, so this is going to be involving the interaction of acetylcholine with that receptor. I have opioid receptors in the vomit center itself. Again, the opioid receptors are many subtypes of opioid receptors. You got kappas, you got deltas, you got mu's. I'm not going to get into all the various subtypes. I'm just going to say opioid receptors. I have CB1 receptors, those are cannabinol receptors, and I'm going to talk about what happens with that and how it's related to emesis in a later lecture. And then another we have is the NK1 receptor, okay, and that is going to be the receptor that interacts with substance P. So what I am saying is that these receptors here are in various neurons that are associated with the vomit center. Again, an oversimplification, but these are the receptors that are involved. So if I have receptors, say for an opioid, then obviously the vomit center is going to be responsive to an opioid. If I have a receptor for NK1, then that means serotonin is going to be interacting with it, again, influencing emesis or nausea. So those are the major receptors associated with the vomit center. Are there others? Probably are. Again, people are always discovering more, but again, this is just kind of a basic treatment of that. On the area postrema side of things, Again, some of these are similar receptors. We have opioid receptors in the area postrema. Of course, that wouldn't surprise you since you're picking up opioid in your blood. You have your NK1 receptors, again, handling substance P. I have cannabinol receptors that I'll talk about later. I have my serotonin receptors there, my 5-HT subtype 3. Then I have my histamine receptors, subtype H1. And then I also have D2 receptors, and these are actually dopamine receptors. Going up to the inner ear aspect of things, these vestibular nuclei, they are going to have some M1 receptors there. Okay, so it's involving, again, acetylcholine and then also histamine receptors. So these are the major receptors, and of course, their concomitant bioactive molecule that's going to bind to them. So as these molecules bind to these receptors, you're going to get some type of change, possibly some type of emetic effect on that. So again, for example, if you have substance P in the blood, it's going to be binding to that NK1 receptor, and those neurons in the area postrema then are going to communicate with the vomit center, and of course, the vomit center and the area postrema are communicating with higher brain centers so that you can have the subjective experience of nausea. So again, a lot of interplay with this. Okay, I want to talk about a couple of other things that I think are rather interesting. So we'll go different color here. Just go back to green. Then I'm going to move down here and talk about, give myself some room. Let's talk about opioids. Typically with opioids, it's a problem in terms of nausea and emesis. Typically what happens, so you go into surgery, now you're in a lot of pain, so they're going to give you morphine to help with the pain, but then the morphine causes you to be nauseated and quite possibly could cause you to vomit. And that's not a particularly pleasant effect, but you kind of have you're kind of stuck between the two. Do I want to deal with the pain or do I want to deal with the nausea and the vomiting? And sometimes that's a hard one to figure out. Morphine, of course, oxycodone. Again, we all know about oxycodone. Again, it's an opioid, and so if you're in pain and if you take oxycodone, it is a reasonable chance that it's going to make you feel ill. When you take that medication, I always say don't take it on an empty stomach, particularly on an empty stomach. You take it on an empty stomach, now you're going to have a pretty quick uptick in your plasma, and it's going to be having a serious conversation with your central trigger zone, and you're probably going to be fairly sick with nausea and vomiting from that. So that's always a problem with opioids, is you have a nausea vomiting issue with them. It turns out, though, that the opioids relative to nausea and vomiting is actually dose dependent. So it turns out that if you have a low dose of opioids, then you're going to have the usual predictable effect. It is going to cause you to be sick and you're probably going to vomit. But what happens is that if you're on a continual low dose, and when I mean by low dose, I'm talking about a dose that you would typically get for pain management. So that type of dose, or you're taking your oxycodone or your codeine or whatever opioid you're on for pain, that would always be on a low dose. So it probably is going to make you feel a little queasy, maybe make you vomit. But what happens is if you continue to take it low dose over a period of days, you'll actually become tolerant of it, and it won't have as much of an effect in terms of nausea and vomiting. And it varies from patient to patient. Typically 5 to 7 days, you'll develop that toleration, and it will no longer make you nauseated or make you vomit. What is interesting, though, is that opioids with high doses have the opposite effect. High-dose opioids actually will not make you nauseated and make you vomit. And that's really curious as to possibly why. A lot of theories are on that, but one of the things that they think, remember I have opioid receptors on the central trigger zone. When those get stimulated, then the response is nausea and vomiting. But many scientists think, though, that when the opioid receptors are being bound to in the vomit center, it actually functions as an antiemetic. It actually dials it down. And the reason for the high dose is if you have a high enough dose, you're shortening the time by which the probability of the opioids making it into the interior region of the brainstem to actually interact with those opioid receptors associated with the vomit center. At least that's the theory for the dose-dependent response on that. The other thing, too, though, is that there are other types of opioids, and one of them is the fentanyl. And the fentanyl is going to be, it's a very powerful opioid, and it's a newer and very, very potent in terms of anti-pain. But what is interesting is that the fentanyl is less emetic inducing than some of the other opioids. And again, a lot of speculation on that in terms of why fentanyl is tolerated better in terms of nausea and vomiting and such. But one of the reasons they think is because the nature of fentanyl itself. Fentanyl is highly lipophilic, which means it travels through cells very, very easily. And so the idea there, or the thinking there, is that the fentanyl has an easier time getting to the vomit center because it is so lipophilic. So that's kind of the hypothesis there. Something interesting to think about. Another thing that I would remind you of is that up in the labyrinth in the inner ear, those cells there also have opioid receptors. So opioid can interact with inner ear and then also cause emesis and nausea. Although it's probably redundant because the opioid interacting so strongly with the central trigger zone, I don't know that the opioid interaction with the inner ear is going to be adding much of anything. Let's talk about Parkinson's disease. Again, Parkinson's disease is when you have in the midbrain an area of the brainstem that's above the pons. You have a little area there called the substantia nigra, and then you have a little area of the substantia nigra called the pars compacta. And those neurons there make dopamine. And when somebody has Parkinson's disease, those neurons die. So part of the Parkinson's process is the neurons in your body that make dopamine start to die. And you have a lot of those dopamine neurons in the substantia nigra pars compacta. And when those neurons die, that's again when you get your classic Parkinson's symptoms. It could be resting tremors. It certainly is muscle rigidity and such. Well, one of the ways that they deal with Parkinson's patients is they try to replace the lost dopamine that those normal neurons would normally put into the brain. And so what they do is they'll take and give Parkinson's patient another compound called levodopa, or sometimes you'll call it just L-dopa. And the L-dopa is converted by the brain to dopamine. And it helps in terms of some of the motor issues that Parkinson's patients have to struggle with. Well, the problem, though, is when they're given L-dopa, which gets converted to dopamine, or if they're given any other dopamine agonist. In other words, an agonist is going to be a molecule that acts like dopamine when it binds to dopaminergic or dopamine receptors. That creates a problem for those patients. So look back up here. So what do we have here? We have D2 receptors. So what's happening here is as the elevated levels of dopamine or an agonist for dopamine possibly binds to D2 receptors in the trigger zone, that then in turn causes nausea and vomiting. So that's always a problem with patients that are on levodopa or L-dopa, is they typically are going to be struggling with nausea and vomiting. It's not 100%, but a lot of patients struggle with that. So they need the L-DOPA to help with their motor movements, but in doing the regimen of L-DOPA for the motor movements, it really makes them sick, and it's a miserable experience for them. I want to close out this piece of the lecture by talking a little bit about chemotherapy. We all know that chemotherapy is hard on the body. We all know that one of the side effects of chemotherapy is going to be some fairly intense nausea and vomiting, because many of the chemotherapy agents are very powerful emetics. They cause this to happen. And so what happens when someone is undergoing chemotherapy, there are two phases to the nausea and the vomiting. We have an acute phase, and then we have a delayed effect. The delayed effect, we're talking anywhere from 36 to 48 hours after the chemotherapy session is over with. The patient may experience another wave of nausea and vomiting. And then you have the acute phase, which is what happens when they become ill during the actual infusion of the chemotherapy drugs. So acute and delayed. The mechanisms are different with this. It is thought with the emesis and the intense nausea that's associated with chemotherapy in the acute phase that that's pretty much going to be a serotonin event. 5-HT, and of course, binding to these 5-HT type 3 receptors. And when that happens, again, you have emesis and nausea. For the delayed, that seems to be a substance P issue. So we're going to have NK1 receptors. Okay, and then you're going to have then substance P binding to them. So delayed, acute, different mechanisms for that. And we'll talk more about this when we talk about the antiemetics, because you have to use one drug to treat the acute phase, and you have to use the other drug to acute, a different type of drug to acute delayed. And I had mentioned this earlier, but what you're dealing with here is going to be also something called anticipatory. Again, this is chemotherapy induced nausea and vomiting. Chemotherapy induced nausea, vomiting, that's what CINV means. And the anticipatory, again, that involves the emotions in the sense that you become to associate the infusion of the chemotherapy agents with nausea, vomiting, and so you're almost anticipating it. So for some patients, the fact that they even come to the clinic, they start to becoming ill and start throwing up before they even have the chemotherapy. And again, that involves higher motor centers. One of the things that I want to mention, though, about the particularly the acute, is that chemotherapy is very, very hard on the GI tract. It agitates it greatly. So again, going back to the serotonin, we spoke of this earlier, the GI tract is irritated by the chemotherapy agents. Again, then that's going to cause a serotonin dump by various cells, enterochromaffin cells perhaps, but other cells perhaps as well, stimulating the vagus, and then here we go. So it is thought, at least one of the major mechanisms in terms of from the GI perspective, is that irritation of the GI tract, communication through the vagus nerve into the vomit center, and now you're having your nausea and your emesis. It's very, very difficult. And we'll talk next time in terms of maybe some drugs that we could give the patient to actually interfere with this process. Okay, so I think that's going to wrap this up. Again, just to remind you that this is kind of oversimplified, but I think it's basic enough for you to remember and basically get your mind around some basic concepts in terms of how this works, because this is going to help you out when it comes to understanding the pharmacological mechanisms to actually push back against emesis and push back against nausea. So we'll see you next time.